Patient safety refers to the harm, injury, and even death that comes about from a mistake made during the delivery of hospital care to a patient. In the United States, we believe that mistakes made in the delivery of health care contribute to the death of patients at a rate equivalent to 2 passenger airplanes crashing without survivors every day. That sort of carnage, if reported accurately on death certificates, would make medical mistakes the 3rd leading cause of death in America, second only to deaths from cancer and cardiovascular disease. But these are bland statistics, while the actual tragedy involves real people with hopes and dreams, who leave behind families and obligations and unfulfilled purposes. We have no shortage of terrible adversities in our society: gun violence, opioid addiction, highway collisions. But patient safety takes a toll that far exceeds these dire issues that receive much greater public attention. I hope to convince you that as a society we can actually make hospitals much safer for patients. We should never need fear for our safety while receiving medical care. America appropriately takes pride in the modern, miraculous capabilities of our hospitals and indeed our entire healthcare system. Healthcare careers do attract dedicated, smart individuals. Those willing to study and navigate the years of grueling training required for professions in medicine deserve our respect and thanks. We know that medical knowledge keeps rapidly growing. Techniques for diagnosis and treatment get constantly more complex. Just to keep pace, medicine has split itself into narrower and narrower fields of expertise. First we added specialties, then subspecialties, and next subspecialties. Prescription medications that once numbered in the dozens now number in the thousands. We now literally have thousands also of distinct surgical procedures. As treatments have grown more potent, errors in treatments have become more deadly. We're going to take a look in this video at how medical practitioners have tried earnestly to reduce mistakes, but have achieved disappointing results. In parts 2 and 3 of this crash course, we will explore new directions that promise far better results. This video series grew out of the Patient Safety Task Force of the Industrial Designers Society of America. The IDSA Patient Safety Task Force came together in 2016 when the IDSA Board of Directors authorized formation of a team to aggressively involve industrial designers in the fight to reduce patient harm resulting from mistakes made in the delivery of health care in American hospitals. Sean Hagan leads this team. The realization that America has a problem with patient safety first broke into public awareness in 1999 when the Institute of Medicine estimated that as many as 98,000 Americans die annually because of preventable mistakes made in their care in our nation's hospitals. Since 1999, several scientific papers have suggested that the size of the problem has increased to a level more than 3 times higher than originally estimated. Defining what constitutes a medical mistake proves complicated. A medical mistake describes harmful events that occur in spite of the genuine, dedicated efforts of hospital staff to restore the health of patients. Experts can disagree about whether a specific bad outcome involved a mistake. Nonetheless, if we treat a patient using the wrong diagnosis, we call that a mistake. If we decide a patient needs a specific medication, but we administer the wrong medication, we call that a mistake. If a surgeon operates on the right leg when the patient's left leg had the problem, we call that a mistake. If experts do not agree that a specific treatment produces the best outcome, we generally do not call alternative treatments a mistake. If a patient slips and falls in the hospital, we may call that a mistake, but we could also simply call it an accident. If a patient gets a new infection while in the hospital, we do call that a mistake even when we cannot identify any specific breach in infection control practices. While we can debate the definition of a mistake, we all agree mistakes occur, and they occur too often. We're tempted to think Good doctors and good nurses don't make mistakes, and respected hospitals are immune to errors. That's not the case. Good people still make mistakes. Highly rated hospitals still allow mistakes to occur. Effective error prevention requires design effort to prevent mistakes. It doesn't just happen because of good intentions. Human minds, regardless of training, intent, or incentives, fall victims to slips, lapses, and aberrant conclusions. Good people still make mistakes. Human mistakes occur more commonly under conditions of stress and fatigue, but they still occur even under ideal conditions. It's easy to find lists of common errors that occur in our hospitals. Error in technique, failure to order indicated testing, treatment delays, omission of a normal precaution, failure to act on a test result, insufficient or ignored monitoring, inadequate patient preparation for a procedure, inadequate follow-up of therapy, incorrect diagnosis, wrong medication dose, or route of administration. Such lists might lead one to conclude that reducing errors requires a different strategy for each item on the list. We would hope to find common themes or approaches to allow more efficiency from our efforts. The current standard approach to error reduction in healthcare says providers must report mistakes. They must document what happened and tabulate how often it happens. Hospitals must analyze mistakes to find the reason the error occurred. This strategy relies on the mantra, "You can't fix what you can't measure." While that adage sounds compelling, it's simply not true. As a nation, we appear to have squandered time and money trying to count mistakes. We thought making error rates public for each hospital would create powerful incentives that would reduce mistakes. That effort has failed because a lack of incentives has never been the problem. The real problem lies in the lack of expertise in mistake prevention. Some have suggested that the solution lies in the creation of a culture of safety in which teams focus on behaviors that minimize errors. But we know that no one can train themselves not to make errors. Others have worked to empower patient advocates to protect patients as they undergo medical treatments. These methods have achieved some success, but that limited success appears to fade over time as diligence wanes, as diligence always does. Fortunately, a few hospitals have created programs that have truly achieved significant sustained error reductions. We're going to spend our time in parts 2 and 3 of this crash course discussing these proven strategies. We want to pivot our national strategy towards these themes of proven efficacy. The IDSA Patient Safety Task Force did not originate these approaches, but they could play a key role in fostering their wider adoption by improving the tools available to healthcare professionals to implement these methods. The skill sets of industrial design can make these strategies easier to apply and more successful in routine practice. Episode 2 will look at the transition of the current prescriptive medical practice mode into a more informative mode of delivery that would enhance both error prevention and fault tolerance. Episode 3 will focus on ways to build safety cues directly into the work processes of hospital care. Both episodes will explain the workings of these strategies and highlight the potential contributions industrial design skills can contribute to this societal imperative.